people, but I think we should get going. We've got a huge amount to get through. Welcome to the second Business for South Africa Business Communicators Forum. We've got two fundamental issues that we're going to deal with today. And these are what they are. I'm going to give a 30-second run through of what this Communicators Forum is intended to achieve. I think many of you were at the launch last week, but I do see some new names and faces. My name is Tim Schultz, and together with Julian Gwillan, we're the co-leads for the B4SA communications team. Then we'll cut straight to the chase. We've got some legal opinion about whether we can force staff to get vaccinated or not, and then which Talita Loubser from our B4SA legal team will be talking us through. And then we have Dr. Ronald Whelan will be talking through where we are in the vaccination program. We've got quite a lot of slides and quite a lot of content to get through, and it's not easy content either. Otherwise we'd all be lawyers or doctors for that matter. So I'm going to kick straight off to let Talita start. Once we have run through the presentations, we will then have an opportunity for questions. The presentation on law will be available later or circulated to the group. We will shortly have a web page at Business for South Africa up and running that you will all be able to access and download it. We don't expect you to become lawyers overnight. Just to remind everybody, Business for South Africa has created this Communicators Forum so that we are able to share relevant information about the vaccines and about the vaccine rollout to business communicators, to directors of corporate affairs. There's quite a number of risk people and HR people who have also joined. The idea is that you will, in your respective companies and professions, be able to use this information to make better decisions about what is happening and how you are giving direction to your staff and to your communities or even to your customers. The information which we were giving, we are primarily promoting the public health information, and so we'll be, as Business for South Africa, directing you to that from time to time, and these meetings will take place every 2 weeks. We are about to onboard some more administrative capacity, so you'll have a little bit more notice, but it'll be every 2 weeks around this time on a Friday. Without taking up any more of your time, let me please hand over to Talita. Lastly, can I say I've got you all on mute, but if new people do join or you unmute yourself by accident, please go back on mute and able to unmute yourselves when we ask questions at the end. With that, Talita, over to you.
Thanks, Tim, and good morning to everyone. I think this issue is probably an example of, well, one of the best examples of how different rights and interests need to be balanced and weighed up against each other. There is no one-size-fits-all answer here, and it is important that we know the context in which we are talking about vaccines and employers' rights and employees' rights, and respect at the end of the day for people's personal beliefs, religious beliefs, their own medical situations, and the like. Just the context, as we all know, the aim of vaccinations is to create herd immunity against COVID. Our government is targeting 67% of the population by the end of the year, and hopefully we will hit that target. There's a phased rollout, healthcare workers, and that is happening. I know firsthand because my husband's a doctor and he got his jab. Phase 2, 17 million people targeted, essential workers such as police officers, retail workers, teachers, people over the age of 60, and persons living with comorbidities, and then the rest of the population. Now, as I said, there are a whole lot of pieces of legislation that one needs to consider. And as an employment lawyer, I would naturally go first to the Employment Equity Act. Now, that act deals with medical testing. Any test, question, inquiry, or any other means designed to ascertain whether an employee has a medical condition. And there are certain parameters within which an employer can require employees to undergo testing. We are undergoing testing every day when we go into the office or to the workplace, and we get our temperatures taken, and we need to fill in all of those questions relating to sore throat, excessive tiredness, coughing, all of those things. Those are medical tests. COVID-19 testing, that is that as well, where we go to a testing site and we get to know whether we test positive or not. But the administration of a vaccine is not testing. That is medical treatment. So as helpful as the Employment Equity Act might be, it is actually not talking to this issue, and it's not on point. So that is not the authority that we will need to rely on. Then the second piece of legislation that I think is the most important and what underlies all of this is the Constitution. Section 15 says everyone has the right to freedom of conscience, religion, thought, belief, and opinion. And there's the well-established principle that employers are required to accommodate the religious belief of employees where they form part of the inherent tenets of that religion, and if it is not going to cause undue hardship on the employer. So already you can see that this right to freedom of conscience and religion is not absolute, and it can be limited in appropriate circumstances. Next, section 12 of the Constitution, everyone has the right to bodily integrity. That means that you have the right to security in and control over what happens to your body. This right is given effect to by the National Health Act. And Tim, you can move on, please. I don't know if I can take control of the screen. Thank you. Section 8 of the National Health Act gives effect to this principle that you have control over your body. The user has the right to participate in decisions affecting her or his personal health and treatment. Section 7 says a healthcare service, which would include the administration of a vaccine, may only be provided with consent. That is the principle, that is where we need to work from. Consent needs to comply with three principles. It needs to be informed, it needs to be specific, and it needs to be voluntarily given. Section 6 tells us what is informed consent. It is where you are informed of your health status, the range of treatment options that's available, the benefits, risks, and consequences typically associated with each option, and the right to refuse treatment and the consequences of that referral. So that last one emphasizes the voluntary nature of the consent. The consent needs to be specific, the provision of a specific health service. So a consent upfront in an employment contract that you will obtain, undergo any treatment as may be required by your employer from time to time will not be an enforceable consent. It needs to be specific. The beauty of law, and employment law in particular, is that there is always a but. So we would have thought, okay, that's the end of it. No. The Act itself, the National Health Act, in Section 7 says there are circumstances in which medical treatment can be administered in the absence of consent. So where it is not voluntary, and perhaps where it is not entirely informed, but it would be a specific health service. And the two that are relevant in our circumstances is if it is authorized by law or by a court order. So if there is a direction or there is legislation to the effect that every single person must be vaccinated, that would be it. There isn't anything like that yet. Or, I don't know if it is anticipated, but certainly as we speak, there is no such law in place. And then Section 7(1)(b) says if it is in order to administer treatment if there is a threat to the user or a group of people who include that user, and that will result in a serious risk to public health. That is our test. Will not being vaccinated constitute a serious risk to public health? Then we move on to another piece of employment legislation, and that's the Occupational Health and Safety Act. Section 8 contains this obligation that the employer must provide and maintain, as far as reasonably practicable, a safe working environment for its employees. And not just employees, also other people who get in contact with the employees of that employer. So it needs to conduct its undertaking in a manner so as to ensure, as far as reasonably practicable, that other persons are not exposed. And as I read this, you will hear there is again a but. It is only as far as reasonably practicable. It is not an absolute. So the general safety regulations provide that the employer may restrict access to the workplace in order to comply with this obligation. And it is precisely on this basis that employers are currently entitled to say, if you test positive for COVID, or if you have been in contact with someone who has tested positive, or if you display the symptoms that we need to disclose, then please go home. Go and do not come into the workplace because you may then be a risk to your co-employees. So that is fine. But excluding employees who are perfectly healthy, but they didn't get the vaccine, can we do the same? That's our question. The principles around informed consent are not new. We all know that our law recognizes dismissals of people in the event that they are too ill to work. And in the context of an ill health process, consultation process with the employee, it often happens that an employer says, please go for a medical examination and share the doctor's reports with us. And the employee can say, yes, I will, or the employee can say, I don't want to go for another medical examination. The employer cannot force the employee to undergo that medical examination. And that doesn't mean that the employer's hands are tied. It just means that the employer must then make decisions on the information available to it. But it cannot force the employee to undergo the examination or to administer treatment in the most extreme example. So if we then look at all of this together, it is a mouthful. We can move on them. It's a balancing of rights. The right to bodily integrity, which means that I need to give informed, voluntary, specific consent. The right that I have to participate in decisions concerning my body, and the right to freedom of religion and belief. None of these rights are absolute, as we saw. They may be limited. So the right to bodily integrity, that may need to be limited if not getting the vaccine amounts to a serious risk to public health. The right to freedom of religion, that again may be limited if accommodation by the employer results in undue hardship. Then we look at the employer's right to conduct its business and specifically its obligation to ensure as far as reasonably practicable, a safe working environment. Then you look at factors such as the severity and scope of the hazards. COVID-19, it is serious. What we know about them, the availability and suitability of other means to mitigate those hazards, and the costs of doing that. And all of that you need to now put in a basket and weigh up. So let's have a little bit of a closer look at these factors. The severity and the scope of the hazards, that depends on the nature of the workplace and the type of work. Clearly, there is a difference between healthcare workers in the front line or pharmaceutical reps who need to be in theatre with the doctors versus someone who is alone in an office doing the company's book. Surely there is a difference. What we know about the hazards and how they can be removed, we know it is serious. We've lived through a year of it already. We know, and it is important that we listen to the science. We know transmission is limited and mitigated by the vaccine. We also know it's not 100% effective. And we know herd immunity may be achieved by 65 to 70% of people vaccinated, and that it is not necessarily so that you need 100% to be vaccinated in order to achieve that goal. The availability of means to remove the hazard. The vaccine is not available to everyone immediately. And the now normal measures, work from home, adequate space, sanitizing, masks, they may need to be with us for some time. But now again, in certain circumstances, these measures may not be possible. So if it is a workplace where we are talking about lots of employees, like call centers, food manufacturing, hospitals, operating theatres, airlines in particular, it may not effectively address the hazard, those new normal measures. Again, office staff, it might be absolutely fine, and that is, you know, what is happening currently, that people are going back to offices with adequate space, mask wearing, all kinds of rules applicable to the canteen and other common areas in the workplace. And then, of course, the cost of doing all of this. Is it the employer who's going to pay? Is it the employee? Those factors. So if we think about the mandatory exclusion of people who are not vaccinated, I think also what is important is to consider the consequence of non-compliance. So if the employer says, all of us can work from home, we would want you to come back to work, perhaps in a phased approach. If you are not vaccinated, don't come to work. You are not permitted to come back to work if you can't show us your certificate. There will be no consequence, bad consequence, employment speaking, if you didn't get vaccinated. Then you will simply continue to work from home. But our office is a vaccinated workplace. So if you want to work from the office, you need to be vaccinated. Then the employee retains the choice to get vaccinated or not. So it is still voluntary. And that, I think, would be in order. But if the employer says you must come to work, you must get the vaccine, if not, you are going to be dismissed, then we are not talking about a voluntary situation. And I'm not saying that is not permissible. I am saying it is permissible in very limited circumstances. And that would be where they risk to public health. So call centers, those kinds of places would probably be entitled to apply a policy like that, potentially. Workplaces where it is serving the public or members of the public, retail, food manufacturing, transport, healthcare workers, airlines, then it is probably in order, because not being vaccinated presents a serious risk to public health. I'm not certain that you can apply, as I said, a one-size-fits-all here, because there may be healthcare workers who are at the front line, like in operating theatres and so on, but there may also be reps who visit GP practices, or there may be the HR department of a call center environment who sits completely separately and who have no interaction with a lot of employees on a daily basis. So I think an individualized assessment is very important. Also, the religious and conscientious objectives, they must be reasonably accommodated unless this would result in undue hardship for the employer. And again, that is very much an assessment that you make on a case-by-case basis. So it will depend on the employer's operations, the percentage of employees who got the vaccine. That may also be relevant. If there is 100 employees in the workplace and 95 had gotten the vaccine, haven't we achieved herd immunity in that workplace? Must those additional 5 employees get the vaccine? Is that then, reasonably and proportionate to the purpose of achieving herd immunity? And again, our labor relations principle that dismissal must be a measure of last resort. We need to consider all of these factors in order to check, is it justified or not? Other things to keep in mind: POPIA, health information, is regarded as special personal information. So employers need to be careful when processing this type of information. The employee under POPIA needs to consent to the processing of their vaccination status, or it needs to be required for the employer to comply with its legal obligations, for example, under the Occupational Health and Safety Act. Again, if the employer relies on consent, the consent must be informed, voluntary, given, and specific. Given all of what I've said, it is probably good to take an approach of educate and encourage rather than threaten and fire. But as I said, it will depend on the very specific circumstances of each workplace and the rights that the employee is relying on in order to say that she or he doesn't want to be vaccinated. Is it religious? Is it just fear of the unknown? But yeah, I think it is important that we all educate and encourage.
Thank you very much, Talita. We're going to move straight on to the next presentation, and then we will take questions at the end. I see there are some questions on the chat, but Ron, if you could please put your presentation up, and then we will deal with everybody later. A reminder for anyone new entering, I've tried to mute you all, but please do mute yourself if you become unmuted.
Tim, can you just confirm that that's displaying correctly, and then we can get going?
Yes, it's displaying correctly.
Okay, good stuff. Morning, everyone. Great to be with you here this morning. Thanks, Tim, for the invite. Much appreciated. Delighted to share some additional insights on COVID, and give you an update on the COVID vaccination program. I recognize a number of names on the group this morning, so good morning to your particular colleagues and friends as well. So I'm Ron Whelan. I'm a Chief Commercial Officer at Discovery Health. I lead Discovery's COVID response both internally and externally. I also work alongside Tim and the rest of the B4SA team on the national vaccine program, where I lead the funding stream, and I sit on the steering committee. So that's sort of a little bit of my background. I'm going to jump straight into the presentation and just get going. Thought we cover three main sections today. Impact of COVID on lives, impact of COVID on livelihoods, and then a quick update on the South Africa vaccine program. As with all of my presentations, for those of you who've joined my webinars here previously, I always start with a bit of a clinical background. And the reason I start with the clinical background is that it's important that we understand the enemy we're up against. So I'll start with just a few slides on the COVID virus to give you some sense on how we think about the virus. The first slide is just an up-close and personal picture of the SARS-CoV-2 virus. Three important elements that you need to be aware of in terms of your SARS-CoV-2. The first one is this yellow strand inside the virus here it's the RNA code. So that's basically the genetic code for the virus. And what happens is when the virus attaches to your cells, it injects this genetic code, and then the genetic code takes over the cell and replicates within the cell. This is important because this is where the variants emanate from. So every time the virus replicates, it has to repeat the code. And if there's an error in that replication process, that's where you end up with variants. The second important point around the virus is the shell here. What's unique about the coronavirus is got a protein and lipid shell, so protein and fat shell. Most viruses only have a protein shell, which makes them very hardy and they survive in the atmosphere for long periods of time. The coronavirus is unique in that it's both fat and protein. What that means is that the coronavirus can actually be destroyed by soap and water. And that's the reason soap and water is equally effective to alcohol detergents against the coronavirus, is this protein lipid shell. The third and very important element of the coronavirus is a spike on the outside of the virus. We call it glycoprotein spike. This is the landing gear for the virus. So this is how the virus attaches to your cells. It's also important in that most of the vaccines are developed against the glycoprotein spike. So those are the three important attributes that you need to be aware of. And this gives you some sense on how variants manifest, how vaccines work, and why soap and water works. Moving along, if you look at the tip of a needle, is typically about 1 millimeter in diameter. The coronavirus is so small, 100 nanometers, that you can fit 10,000 coronavirus particles on the tip of a needle. 10,000 coronavirus particles. And that these viral particles are typically carried in respiratory droplets. Less than that, but just gives you some sense on how small this is. If you were then to blow on the tip of that needle, you can imagine what would happen. Now think of it as a dandelion effect. We've all as kids and sometimes as adults as well, blown on a dandelion fragments go out into the air. They travel for a certain amount of time and then they drop and land somewhere along the line. Same thing happens with coronavirus respiratory particles, is they go out into the atmosphere for varying distances, they disperse in the atmosphere and then they land. And that's really what we mean by airborne in relation to coronavirus. And then finally is your clinical sort of clinical 101. Here's an electron micrograph photo of a regular face mask. In fact, it's not a regular face mask. This is an N95 face mask. You can see how granular this picture is, 50 micrometers in the bottom right-hand corner there. So it's much, much stronger than a regular microscope. You can see this entanglement of different particles in the face mask. In fact, just to give you some sense on how big this face, how close up this is, that's a speck of dust, tiny speck of dust, single speck of dust within a face mask. And I think this gives you some sense on why face masks are so effective at preventing cross-contamination through the coronavirus. So these particles capture the respiratory droplets. Inside those respiratory droplets, you've then got the viral particles. So that's your sort of whirlwind tour through coronavirus virology. We then move on to some of the insights around impact on lives. I think where I'd like to start this off is just a comparison between wave 1 and wave 2. What you'll see from this slide is that wave 2 was 1.5 times higher than wave 1. And I think we all felt this across the system during the course of December. It certainly felt like it was worse. It certainly felt like many more colleagues and employees got infected during wave 2 as in comparison with wave 1. Looking at some of the discovery statistics on this, what we found in wave 2 is that the higher socioeconomic classes were more predominantly hit in wave 2 than they were in wave 1. A lot of the spread of infection actually happened on the back of super spreader events coming out of post-matric gatherings towards the end of November last year. And that may be part of what's driving that. We had significantly higher exposure on Discovery Life. So we had 1.2 times 123%, sorry, more than that, 123% of life claims paid. So almost more than double the life claims paid in wave 2 versus wave 1. We had higher admission rates, but interestingly enough, with the higher admission rates, we also had lower hospital claims, so 18% lower hospital claims. That was predominantly driven by a 37% reduction in the average hospital length of stay for a COVID admission. Why that happened was a few reasons. The first reason is we've learned how to manage your coronavirus during the course of 2020. The second reason is Discovery put a range of measures and initiatives in place that enabled us to take care of members in home settings. So we provided nursing services, providing GP services, specialist service in people's homes, which is quite an exciting development going forward. I think you would all agree that it's much better to recover at home than in a hospital. So that was the reason for the lower length of stay. There were 3 underlying reasons we ended up with a wave 2 outbreak. And the reason I put up this slide is this will give us a clue on how to prevent a wave 3 outbreak. The first reason on the left-hand side here, you can see Google mobility trends. And notice how they dropped off in the severe lockdowns, and then gradually migrated back to baseline. And then around about the middle of November, they crossed our average baseline over time. And that's where the spike started to happen. In fact, what's interesting in the vitality data is that we saw increased mobility after hours, which suggests that people were starting to socialize more towards the end of November. When you compared the driving data for November versus the driving data for July, much more after hours driving. The second thing that happened, and I alluded to it on the previous slide, is at the end of November, there were these post-matric events. That blue line there that you can see is the 16 to 20-year-old age line. And this is positive tests per million on Discovery data. You can see what a spike we had in 16 to 20-year-old infections at the end of November. We're completely out of kilter. And we certainly knew of many cases at that point and got very concerned about those kids coming back to family members during the course of December. Another interesting thing happened on the back of this super spreader. When we looked at our flight data, we found a 16 times higher risk of infection on flights during this period than during the rest of the year. So what that suggests is these kids unknowingly were boarding flights, didn't know that they were infected, but were infected at the time, and then passed on the infections to other participants of those flights. So I thought that was a really interesting stat. And then the third reason on the right-hand side of the page for the wave 2 outbreak is the variant. And what you'll see on this page here are the different variants that have manifested in South Africa throughout the pandemic. The red and the gray line are deaths and infections. So there's our wave 1, there's our wave 2. You can see that wave 1 was caused by the 20B variant more than likely. There's a spike in the 20B variant. And then you can see very clearly that wave 2 was caused by the N501Y.V2 variant. So this is what caused our wave 2 outbreak, that new variant manifesting. So if you take a step back from this, I think you'll acknowledge there's lots to learn around preventing a third wave, reducing mobility, reducing super spreader events, and watching very carefully for any new variants. So that's sort of the 3 main messages from this page. Looking ahead, our actuaries have done some modeling on the third wave. We've modeled 3 particular scenarios. So there's wave 1, there's wave 2 on the left-hand side of the page. The green scenario is the worst, apologies for that. The green scenario is the worst case scenario. So this is a scenario where we end up with super spreader events at Easter, and I think we all acknowledge that there's super spreader event. There's definite risk of super spreader events at Easter, particularly around your church gatherings. Then there's a red scenario, which is super spreader events at Easter with the reinfections, but with a vaccine rollout. Yeah, so you could see the impact of a vaccine rollout program, yeah, the green line to the red line there, and significant number of lives saved between those two lines there. So it's somewhere around your 50,000 lives, 48,000 lives saved between the green line and the red line. And this is why Tim, myself, and the rest of the B4SA crew are working as hard as we can to accelerate your vaccine procurement. So significant impact on those. And then, of course, there's another scenario where we just see a wave 2 runoff. There is some potential of this happening. We don't think this is likely. We're probably going to end up somewhere in this this sort of zone here. So that's our projections around the third wave. Critical to this is watching the Easter risk and then driving vaccinations as hard as we can. Moving on to some thoughts on livelihoods. I think it's common cause that South Africa's economy has experienced a significant contraction during the coronavirus pandemic. So here's latest stats out of SARB, Stats SA, RMB, and so on and so forth. Somewhere around an 8 to 9% in contraction on GDP. Some a little bit shorter than some estimates, a little bit longer than in other estimates. I think, and then a range of GDP growth scenarios over the next 5 years or so, ranging anywhere between sort of 1.5% and 6%, and anyone's guess around where we end up at. I think the right-hand side of the page is probably the most important part, in that there's three recovery curves, that could play out in South Africa. The first curve gets us back to pre-COVID GDP levels within about 2021. That's kind of apologies, gets us back to that within about 3 years. That's the upside scenario. We return to the baseline within 3 years. Our baseline scenario is you return to 2019 GDP levels within 4 years, and then the downside scenario, we return to GDP levels within 7 years. So this is only by around about 2025, 2026, or we're then back to pre-COVID GDP levels. I think none of us want to go down this curve, but it's certainly going to take a concerted effort between government and the private sector to avoid this sort of scenario. That would really effectively put South Africa 7 years back on GDP. So moving ahead to just some of the health system impact here, we think of lives and livelihood. We think of livelihoods both as economic livelihoods. That's what we all participate in. But I think what's been quite interesting for us to watch, and quite concerning for us to watch, is the impact of COVID on our healthcare professionals. This is less publicized statistics, and I'll specifically share it with you today just to give you a sense on the challenges your healthcare practitioners have faced across our system. So if we start out with general practitioners, who we all know, you can see how depressed general practitioner revenue has been since March last year. So general practitioners are somewhere around 28% below their baseline earnings from previous years. This is just people not going to GPs as often as they were going before, both for acute and chronic conditions. The pediatricians are down about 19% on average on a PLP per life per month year basis, but you're already dipped very low into the red year. The pediatrician dip off is both as a result of reduced health-seeking behavior, so people looking for pediatricians, but interestingly, and I think what we're seeing in our data, is also as a result of lower disease burden. So what we typically see a lot of pediatrician visits on is respiratory syncytial virus. It's a common virus in our environment. It typically affects your kids. Kids typically then get runny noses and cough and various other respiratory symptoms. Last year we had hardly any respiratory syncytial virus or RSV virus, and that's part of the reason your pediatrician levels were so low. But there was also reduced health-seeking behavior. Orthopedics is down for obvious reasons. People are delaying their surgeries. But what is interesting to watch is look how psychologists have increased. And this is something concerning for us to watch across your business landscape. So mental health is a real issue. And then pathology costs are up. And this is primarily result of COVID testing. So COVID testing is costing the economy and the medical insurance industry significant sums of money, particularly given that COVID test costs 850 Rand a test. So this is quite a concerning picture for us going forward, and something we need to work on the pathologists with. Moving into the vaccine program update, I think to start out, just to say the vaccines that are currently in the marketplace, the likes of Moderna, Pfizer, J&J, AstraZeneca as well, are extremely effective, extremely effective. These are unheard of effectiveness rates. So the Moderna and the Pfizer vaccine are 94, 95% effective. And just to help you calibrate on those numbers, the average flu vaccine is about 3% effective. And it varies from year to year. We have a different flu vaccine every year. Even at 40%, we reduce hospitalizations, we reduce deaths. Now, can you imagine the impact of 95% effective? And here's an image for you out of Israel that gives you a sense on how effective this is. So Israel's been rolling out predominantly on the Pfizer-BioNTech vaccine. They have about 60% of their population now vaccinated. What we're illustrating here is the light blue line is people who are vaccinated. The dark gray line is people who are unvaccinated. And what you can see here is the crocodile jaw across all of these charts here. Reduced infection, vaccinated versus unvaccinated. Reduced symptomatic COVID, vaccinated versus unvaccinated. Reduced hospital admissions, reduced severe COVID, and then most importantly, reduced death. So, I mean, isn't that a remarkable crocodile jaw there in reducing deaths? And in fact, I think what's important to point out around this is it's a shame we lost the AstraZeneca vaccine, because we tested the AstraZeneca vaccine only against COVID infection, so reducing infection and reducing mild infection. We didn't test the AstraZeneca vaccine against your hospitalizations, severe COVID, and death. So there is a very real chance that we've sent the AstraZeneca vaccine back, but it would have had significant impact on higher risk populations. Moving towards the economic impact of vaccines, this is conclusive. I'm not going to spend enormous time here other than to say there's international research that says, looks at a 12 times economic return on any vaccination program. So here's I think it's your work out of the World Economic Forum. From a South Africa perspective, we've done a similar piece of work within the B4SA structures, supported by Deloitte and the Discovery Actuarial team, looking at the impact of the South Africa program. So anywhere between a 6 and a 25 times return. The overall program will cost somewhere between 10.3 and 13.5 billion. That's fully loaded. That's vaccines, that's vaccinations, that's the public sector and the private sector. And at that sort of bill, the return on investments is just remarkable. So I think it is something that as a business sector need to be investing in and helping to accelerate the rollout in any way, shape, or form. Insofar our program, Talita alluded to the three phases a little bit earlier on, so I'm not going to go into the detail around the population around the three phases. Just sort of point out on this page that together with government B4SA, we have calculated the number of doses required for each of these phases and are actively hunting doses for each of these phases. I think the good news is the hunting for doses is going well. So in aggregate, we've got a healthy number of doses in the pipeline. The bad news is that the doses really only start to ramp up from about June onwards. So we've got a gap between April and May around doses. There are some doses, there will be some doses in the system, but certainly not as many doses as we would like to accelerate the vaccination of high-risk populations. So that's something we're working very, very hard on at the moment to see whether there's any chance of covering that gap. It is challenging because vaccine manufacturers globally have not yet ramped up production, and there's significant supply-demand deficits. From a South Africa program perspective, I think a few important points to make on this slide. Yes, if you just focus top right-hand side of the slide, you'll see that we're targeting somewhere between 250 and 300,000 vaccinations a day. We need to get to that level somewhere between sort of June, July, August, September, and October. That's the cadence we need to be vaccinating at to get through the program before the end of the year, and most importantly, to get through high-risk populations by midwinter. This is going to take a concerted effort from the public sector and the private sector, but is not unachievable. And I want to emphasize that point. So the UK is vaccinating at over 400,000 people a day. Israel is vaccinating at over 160,000 people a day. Israel is a population of 8 million people at 160,000 people a day that they're vaccinating. The UK, 400,000 across a population of about 60 million, similar to South Africa. So 250,000 to 300,000 is certainly within our range. So this is the demand side. On the supply side, you'll see below, and this is what I alluded to in the previous slide, is we have a gap in supply around March, April, May. This is the concerning period from us from a supply perspective. We do have very good supply pipeline starting from June, July, August, September onwards. And that's the reason we'll definitely be able to consume those vaccines as soon as they arrive in the country. There are importantly some risks associated with that, particularly on the J&J vaccine that's just starting to manufacture. But I think we're feeling pretty confident for July, August, September, October. But this is the gap that we must cover urgently. So a few messages for you and your businesses, I guess, just a call to action, if you will, based on what you've seen coming out of this presentation. I've tried to focus on a few nuggets. I think the first nugget is we must all rally around preventing and suppressing the third wave. We know what causes these waves: increased mobility, super spreader events, new variants, and we also know how we can prevent these third waves. So we've got to work together to prevent a third wave, potential to save many lives. I think secondly, without laboring the point, we have to work together to accelerate the vaccine rollout. And anything we could do on that front is critical, both in terms of throughput capacity as well as in terms of vaccine supply. And then I think more broadly, we have to acknowledge that our world of work changed. Our employees are going to need mental health support and various of support. We've got new working models that we've got to adapt to. So I think we should just accept that the world of work has changed and move to this new world of work. And then we've got to together invest in getting South Africa globally competitive. I think despite the devastating effect of the COVID-19 pandemic, it's also opened opportunities around global connectivity. So there's opportunities to leverage global connectivity in new and innovative ways and to make South Africa more globally competitive. And then finally, I think it's a question of just adjusting to the new normal. The world has changed. There's no going back to where we were. We are where we are, and I think it's an exciting place to be in many respects, and opens up certainly lots of opportunities for the future. And then I'll finish it off with a quick marketing punt, because this is a marketing group or communications group. This is just to remind you of the COVID Alert app run by the National Department of Health, a very, very powerful tool for restarting the economy and for keeping your employees safe and healthy. There's no location tracking on this app. All it does is it gives you advanced warning when you've been in contact with someone who's potentially tested positive for COVID. The app works brilliantly. My wife has now had 2 cautions. She's a healthcare professional, and on each of those cautions, she's then been able to quarantine quickly and prevent the rest of her colleagues and her family from getting infected. I think that's it, Tim. Thanks again for hosting us. Happy to take any questions.
Thanks very much, Ron and Talita. There are a number of questions that have emerged on the chat. I know we don't have a huge amount of time. We've got some hard stops amongst our presenters. But could I ask that anyone who wants to ask a question, if you could just put up your hand, then we can unmute you and you can ask the question. While you're composing yourself, let me just answer some of the questions on the chat. Firstly, the presentations and recordings of last week's Business Communicators Forum, if you look down at the invitation you got either by email or in the diary invite, there are some links below where you can download those presentations and indeed the entire recording. Secondly, perhaps if I can ask Ron, there's just some questions about when phase 2 is likely to start. Could you please just expand a little bit on that dynamic?
Yeah, I'm going to try and be very brief on these answers so that we can get through the questions quickly, Tim. I mean, the government has indicated the end of April. So it means that ideally we into phase 2 from May onwards. I think there are 2 critical constraints in that. One is we've got to get through phase 1 first. So that's we've got to accelerate phase 1. So that's priority number 1. And then priority number 2, as I mentioned in the presentation, we've got to make sure we've got vaccines available for the end of April. So as I said, we've got a gap in May that we've got to cover. But as it stands, the plan is to get phase 2 underway at the end of April, beginning May.
Thanks. John Purchase, I see you have your hand up.
Yeah, thank you very much for great presentations. Just on the phase 2 and who would qualify for that, I just posted in the chat section 2 that you mentioned essential workers and you said such as, and it didn't qualify everybody. And in the food value chain, you indicated the retail workers, but we have a sector or groups of essential workers in the value chain that work in confined spaces. In other words, where your risk is pretty high, such as in abattoirs and fruit pack houses, etc. We feel a strong necessity to have these workers that are in the confined spaces and essential workers to have them vaccinated. You might remember in America that one of the major focus areas was in the meat pack houses and how it affected food security and meat supply in the US. And that actually speaks to the risk that you have in these areas. So I want to ask, can we still make representation in terms of who should be included in the phase 2? And if so, what is that process?
Yeah, thanks for that question, John. It's a few things there. One is the Ministerial Advisory Committee, led by Professor Barry Shube, are developing all of the protocols around essential workers in collaboration with the National Department of Health. I think in terms of making representation, it's best to work through the B4SA channels on that. And then, they will put those representations forward to both the Ministerial Advisory Committee and the National Department of Health. I think the second point, John, is that certainly from a clinical perspective, what we see is you get the biggest mortality and morbidity impact by focusing on higher age populations. So the people who are most prone to death are the elderly and people with severe comorbidities. And most countries, if not most countries globally, have run their programs on an age basis until they're able to get you through the over 60s. Once you're through the over 60s, then you can kind of start to migrate into the rest of the system.
Thank you very much, Ron. I don't see another hand at the moment. Is anyone who wants to ask a question, either shout out or on the chat? Yes, Zintle.
Hi, Zintle, thank you. My question is, in terms of the rollout, besides just using, hospitals, clinics, or pharmaceuticals or chemists or whatever, in terms of the vaccination, when that happens, is there another way within which those are going to be done? So, for example, some other countries are using companies, so companies with wellness centers, and they're literally saying that, employees can bring in their families and they're going to be vaccinated through those outlets. Is that something that South Africa is considering or not, and which other routes are being considered, just so that we can actually get a fast-paced way within which this is done? Thank you.
Yeah, great question. Great question. A short answer to your question is yes, and 2 big initiatives underway on that. I think firstly, we have enormous occupational healthcare infrastructure across South Africa. Mining sector or the manufacturing sector, the industrial sector. I saw Hilco on the call, who's your head of healthcare at Sasol, and Hilco basically runs a healthcare organization. So we should be leveraging that capacity. We've also got conversations here with various mining companies underway. So that's a definite opportunity. I think the second opportunity, and very importantly, is we've got to set up mass vaccination sites. Mass vaccination sites here globally run out of churches, run out of stadiums, run out of conference centers. And South Africa is exploring all of those opportunities. I can tell you there's a big piece of work currently underway around big sites that will allow us to get big throughput capacity so that we're able to accelerate this program. Our estimates is that we should be able to get well over 50,000, 60,000 vaccinations a day through these mass vaccination sites. That, by the way, that's not only important for throughput, it's also important in that South Africa's vaccine program will hit its peak in the middle of winter when our healthcare system is already under significant strain. So we can't put more strain on our existing healthcare infrastructure. We've got to pull some of that strain out through these mass vaccination sites.
Thank you. Ron, I see Paul Hardman. You have a question?
Yeah, thanks, Tim. Perhaps a question for both speakers and a comment just perhaps in relation to people that have had COVID and then vaccines. Should people get vaccinated if they've either tested? And I'm thinking particularly of the group that we hear of stats that up to 50% of the population may have had COVID but not realized it. So there's a bit of an unknown there. And so firstly, from a clinical point of view, what would a vaccine help those people, or should they still go for a vaccine? And then also tying a bit up with the legal side in terms of, if they think they might have had it, or if they have antibody test positive, how does that come into play from a requirements point of view in the workplace? Thank you.
Let me answer the clinical question, because that's the easy one to answer. Then I'll leave the hard question to Talita. The easy question is you should get the vaccine regardless. And there's a very simple reason for that, in that these vaccines are very effective at creating antibodies. So they create many more antibodies in most instances than any vaccine would create. They're an antibody creating machine. And what that does is, you never know what your level of infection was and what your level of antibodies was. All you know is I've got antibodies or I don't have antibodies. You never know your level. Vaccines shoot you through the roof around your antibodies. So everyone, regardless of whether you've got antibodies or regardless of whether you've been infected, must get vaccinated.
Thanks, Talita.
Before I'm going to answer, I actually want to ask Ron, how long does that jab last? Will we have to get this vaccine every year?
Yeah, $1 million question. We don't know yet. Remember, we've only been living with COVID for a year, and we've only been living with vaccines at scale now for 3 months. All indications are at the moment we will likely need booster doses for a few years to come. But that's science that we'll be following closely now over the next 6 months or so. But it looks like we're going to have boosters. And the reason for that is more the replication of the virus. So the risk of this virus is mutating a lot more than any of us expected it to mutate.
In relation to Paul's second question, the same principle will apply. We will need to make sure on a case-by-case basis that it is actually a requirement in relation to the risk to co-employees or members of the public to have a firm requirement that someone is vaccinated, bearing in mind the objections that that person can raise from a religious perspective. I don't think a reason like I don't want to be vaccinated because I don't want to is enough where there is a serious risk to public health. And in those circumstances, the employer will need to deal with that employee in accordance with the applicable legal principles around incapacity or retrenchment or whatever the case may be, or even refusal to obey reasonable instruction. You want to go that way, but that is something that we will have to assess on a case-by-case basis with taking legal advice.
Talita and Ron, can I ask you a question? It's Rochelle from Anglo American. Have you had any experience within the industry? Are we experiencing a lot of hesitancy with our different markets, or are they actually lining up to get the vaccine? Because I'm wondering if we're not all preparing for this hesitancy And actually, the minute we make the product available, people are actually very willing to take it.
Yeah, geez, it's a great question. All I can comment on is what we've seen in other markets is it starts out with quite a lot of hesitancy, and then it sort of migrates to FOMO, is what we've seen in other markets. And you sort of you end up with an uptick, and seems to sort of spread. It seems to be socially acceptable. That being said, I mean, we don't know how this is going to manifest in South Africa, and we don't know what the anti-vaxxer sentiment is, how that's going to play out. All I know is we have to be combating the anti-vaxxer sentiment. These vaccines are entirely safe. They have gone through all of the rigorous processes, and they are extremely effective. So I think as a business community and as leaders across South Africa, we have to be working hard against any anti-vaxxer sentiment.
Thanks, Ron. If I could also just add to that, I think the kinds of challenge we're going to have are going to change as this unfolds. So at the moment, it's quite theoretical for most people because access to the vaccine is very restricted to healthcare workers, and they're getting vaccinated effectively in their place of work or in hospitals and clinics and so on that they know of. It's going to be much more difficult once this goes out to phase 2 and the general population, because then you've got people who are not healthcare workers who are having to be coordinated, not just to overcome any hesitancy they might have, but also about where they go to get vaccinated in the right sort of sequence, if it's a double shot vaccine, to come back again and so on. So we're going to have both a vaccine hesitancy challenge, but also just a management challenge of getting millions of people to get vaccinated at the right place and also in the right sequence. And that's where the FOMO also becomes a communications challenge and a management challenge as well. Some people will want to hold back and some people want to push themselves into the front of the queue. Everyone will have their own individual reasons, often very good reasons for those. So those are the kinds of challenges that we're going to face as a whole society, but which will also be particularly relevant for the businesses that are assisting with the administration of the vaccine. Effectively, you're going to become part of the public healthcare frontline worker, whether you work for a private sector company or whether you work for the government. So there's a lot that we're going to have to deal with, and the quicker we can start to wrap our heads around that, the more likely we are to be able to respond as business and give direction to our staff and communities. So I'm afraid we've got to the end of our session. We're a few minutes over. Everyone does have a hard stop, but I'm very gratified to see so many of you are still here. If there's not if there's not a final question, I don't see one. Let me thank everybody. Yes, we do have a final question.
Master Rami, are there any plans to pre-register the general population ahead and in advance, knowing that there will be pandemonium when that eventually happens?
Yeah, great question. So I think a few points on that. Number one is the electronic vaccination. The EVDS system will be the primary system for registration. The team is working extremely hard on preparing that system now for phase 2. It'll work in a similar way to what it worked in phase 1, and then registration will open up on that system in a staged way. The way it then works is once you registered on the EVDS system, it then ranks you according to your age and your morbidity risk, and then it begins to schedule based on available sites and available supply, and then you get a voucher when it's your turn to come up. It works in a similar way to other countries, but lots of work that still needs to get done on the EVDS system, and Tim and team will certainly communicate once that is ready and available for registration.
Thank you very much, Ron and everybody. We are going to be, so thank you for everyone who's put their emails on the chat. If you didn't receive it directly from us, that will help us bulk out our database. We will be sharing a recording of this session which you can then look at your leisure. We're also going to be holding these communicators sessions every 2 weeks on a Friday, around about this time, so 11 to 12, 10:30 to 11:30, around then. We will try and get these into your diaries as well. I understand we are having to move quite quickly, sometimes at short notice. Thanks so much to the speakers and also for all the attendees. We are going to end it there. Thank you, everybody.